Hello and welcome to the APROBIO Professional Discovery Academy web seminar, Enlisting Probiotics in the Management of IBS with gastroenterologist Dr. David Armstrong. This is the final session of a fourth-part series entitled Medicine or Snake Oil? Is there a role for probiotics in our clinical practice? My name is Dragana Skokovic-Sanjic. I'm your moderator for today. I'm a clinical pharmacist in primary care in Hamilton, Canada. I'm also the author of the Clinical Guide to Probiotic Products available in the US and in Canada. And I coordinate that project since 2008. And that's the reason, I guess, why I'm here speaking with you. And it's the reason I'm so honored and pleased to host Dr. David Armstrong today. The Alliance, or APROBIO, is a group called Alliance for Education on Probiotics. We are dedicated to establishing probiotics as a frontline therapy for the protection, restoration, and enhancement of human health. And we are a trusted global resource for evidence-based information on probiotic products. APROBIO has been compiling, reviewing, and summarizing evidence on specific probiotic products and associated applications since 2008. Before we ask Dr. Armstrong to start his presentation, please join us in thanking Executive Pharma for unrestricted education grant to make this enlightening four-part education series possible. We appreciate their support and thank them for bringing us together to learn. Please remember that this event has been created for you. You are muted, but you may ask as many questions as you like as we go through the presentation. Simply try to type your question in the chat feature, and we will make sure to answer as many questions as possible at the end of Dr. Armstrong's presentation. We are here today to learn. During today's session with Dr. Armstrong, we will explore the irritable bowel syndrome and the use of probiotics as a management tool. We will look at why IBS is so difficult to manage, how it impacts the quality of life and clinic resources, relevant evidence, and appropriate probiotic selection. Now I'd like to introduce you to our speaker. Dr. David Armstrong is Professor of Medicine at McMaster University and Consultant Gastroenterologist at Hamilton Health Sciences. He graduated from Cambridge University and King's College Hospital in the 1970s. After 2 years as a family practitioner in Labrador, he completed his clinical and research training in the UK, Switzerland, and Canada. His clinical and research interests include GERD, dyspepsia, inflammatory bowel disease, nutrition, short bowel syndrome, colon cancer screening, and quality and endoscopy with over 300 publications. He has been a principal investigator for numerous clinical trials and taken part in many guideline consensus conferences. He was president of the Canadian Association of Gastroenterology from 2016 to 2018. He is a chair of the Canadian National Colon Cancer Screening Network, treasurer of the International Working Group for the Classification of Esophagitis, chair of the Global Guidelines Committee for the World Gastroenterology Organization, and a board member of the Canadian Digestive Health Foundation. We are pleased to have Dr. Armstrong on board of the Scientific Advisory Committee with the Alliance for Education on Probiotics, or APROBIO. Very impressive introduction, Dr. Armstrong. And again, Dr. Armstrong, I believe you have a control of the slides now. So welcome, Dr. Armstrong.
Thank you very much indeed, Dragana, and thanks also to APROBIO for the invitation to speak about the irritable bowel syndrome. This actually is a huge topic, and so I'll try and give you a whistle-stop tour through the irritable bowel syndrome and try and put probiotics in the context of an understanding of the irritable bowel syndrome and in the context of the other treatments that are available. So the goals for you at the end of this talk, or at least for me in speaking to you, is that by the end of this, you may understand rather better why the irritable bowel syndrome, or IBS, is so difficult to manage, recognize the impact of IBS on patient quality of life and the disproportionate impact it has on clinic resources, outline the steps and stages to managing communication with IBS patients, review the evidence supporting probiotic therapy as an effective therapy option, and selecting the proper probiotic for IBS patients. I'll do my best with this, as I say, recognizing that this is a complex condition. So what I want to do is to start out really by defining what is the irritable bowel syndrome. And this has been a subject of guidelines and consensus conferences over the decades, starting really probably with the first Rome consensus, which unsurprisingly was in Rome, and is probably now about 40 years ago. And so part of the challenge is that the irritable bowel syndrome is not actually a single disease. It's defined, and most recently by the Rome 4 criteria, as recurrent abdominal pain, on average at least 1 day a week in the last 3 months, associated with 2 or more of the following: that it's related to defecation, that the pain is associated with a change in the frequency of stool, or that the pain is associated with a change in the form or appearance of the stool. So what do we mean by the form or the appearance of the stool? Well, if we look at this, this is a delightful chart, but this shows actually a standardized way of assessing and describing the form of the stool. It is the Bristol Stool Form Scale that was developed by Ken Heaton many decades ago. And you can see at the top end is the constipation end of the spectrum, and at the bottom is the diarrhea end of the spectrum. And this is important because the diagnosis and the management of the irritable bowel syndrome is based to a large extent on the subtypes, not exclusively, but those patients who have constipation predominant IBS with more than 25% of stools being constipated, that is Bristol types 1 and 2, are treated rather differently from those who have diarrhea predominant, where the loose or watery stools, type 6 or 7, predominate. But just to make life complicated, there is also mixed IBS, where more than 25% of the time the stools may be either hard or soft, and then the undifferentiated, which forms the rest down on the bottom left-hand corner. So you can see already, if we look at patient symptoms, it already encompasses a wide range of symptoms and manifestations. And to put this in context, this is a horrendously complex slide, and I won't go through it all in detail, but I do want to highlight some things which are really important when we think about the irritable bowel syndrome, what it is that plays a role in people developing the irritable bowel syndrome, and therefore how variable are the different treatment approaches that we need to consider. So as I say, this is not a single disease. This is not like tuberculosis or an infection where there's an antibiotic that treats it. What we have with irritable bowel syndrome encompasses potential abnormalities from the level of the microbiome and the gut through to its enteric nervous system, to the spinal cord, to the central nervous system, and its effects on our well-being. So if you look at the bottom on the left-hand side here, you can see that the gut lumen, the bowel lumen in the small and large intestine, includes microbes, it includes food, it includes metabolites, things that are produced when foods are broken down, things produced by bacteria and viruses and all sorts of other things. And it's this soup that the bowel wall then has to detect, it has to absorb food, it has to keep infections out, it keeps toxins out. And all of this is monitored by the enteric nervous system, these nerves over on the left-hand side that try and sense what's going on, and the immune system that senses whether there are bits of bacteria or other things that need to be fought off. All of these then communicate with each other. They send messages that go through the bloodstream, that go through the nervous system. And on the right-hand side, all of this information then goes up through the spinal cord and through the autonomic nervous system up to the brain, where it then, all of this information is integrated, and then messages are sent down to the gastrointestinal tract and to our sensations, telling us how to deal with our food, with our day-to-day life. And it's this complex interaction that leads to changes in mood, to anxiety, to depression, and leads to changes in motility that can cause pain, cramping, constipation, and diarrhea. And so without going into too much detail in this, what I hope you can understand or realize from this is the enormous number of different things that we need to try and modify if we're to try and help this syndrome, this mixture of symptoms that comes as part of the irritable bowel syndrome. And the other thing is that the stomach, our bodies have a limited number of ways of complaining to us. So the symptoms of the irritable bowel syndrome can look like symptoms from other conditions. And it's really important to know that IBS is not, as I've said, a single condition for which there is one specific known cause or treatment. It's not purely a psychological disease. So a diagnosis of the irritable bowel syndrome doesn't mean that it's all in your head. It means that whatever's going on is affecting your head. It's affecting the way that your head deals with the rest of the world, but it's not purely located up there as a psychosomatic disease. IBS is not a wolf in sheep's clothing. It's not symptoms which are just hiding a cancer or Crohn's disease or colitis or celiac disease, pancreatic disease, carbohydrate intolerance, fructose intolerance, lactose intolerance, food allergies. These are all things that can produce similar symptoms, but IBS is not something that's covering these, and it's not a diagnosis that has missed all of these conditions. And so, excuse me, the other thing is that it's not, as I say, a food allergy. And the other thing to remember is we talk about making a positive diagnosis. That is, IBS is not a diagnosis of last resort. It's not the diagnosis that we give out once we've gone through every possible test that we can think of. What we try to do is to look at the picture and the patterns of the symptoms and what triggers them, because that is usually characteristic of IBS, and that leads us down a management strategy, a way of dealing with symptoms, which I'm going to talk about later in terms of the different treatment options that are available. But it's really important to know that the goal is not to try and think of every test under the sun before making a diagnosis. Why should we care? Well, there are a couple of things. One is that IBS has a huge effect on individuals' quality of life and on the healthcare system. You can imagine with all the investigations that need to be done, there is the potential for high costs, and for something that is common, like the irritable bowel syndrome, the potential costs to the system and the costs to individuals are really great. And this shows from some work from Alex Ford and colleagues a couple of years ago, the prevalence, how common irritable bowel syndrome is. And you can see here that overall, it's one of the most common chronic global conditions, and that about 11% of the population, adult population worldwide, that is more than 1 in 10, has the irritable bowel syndrome. And if we look at Canada, actually that number is significantly higher. It's about 18%, which is about 1 in 5 to 1 in 6 people, with about just under half having diarrhea predominant irritable bowel syndrome. And it accounts for about 12%, that is 1 in 8 primary care visits. So it's clearly a big problem for the healthcare system, but also for the individuals. 2/3 of individuals indicate that IBS interferes with their daily life. Half of people surveyed say that they miss work or school due to their IBS. Over half feel symptoms of fatigue. About 40 to 60% experience psychological symptoms with anxiety and depression related to the IBS. And a quarter of people say that they would actually forego a high proportion of people say that they would forego 25% of the remaining life if they could deal with their symptoms. So this is clearly a major deal for people with irritable bowel syndrome. And it also costs the system, whether it's the individuals or the healthcare system. Data from the US suggests that patients with IBS symptoms, the costs for healthcare are about $2,000 higher for those with IBS symptoms than for those who do not have IBS. And on average, it takes about 4 years to make a diagnosis of irritable bowel syndrome, clearly something that we should be able to get to achieve more rapidly. And in Canada, about just under half of the costs of IBS management are due to the diagnostic test. So again, if we can reduce that, make a positive diagnosis, then we can reduce the discomfort that people go through by having these tests and the costs to the system, so that we can actually improve the care for IBS significantly. So if we're looking to manage IBS, what are the options that we have? Well, one of the things that's important, and you'll see, we all see guidelines that are published and they come out in the press and they say the experts have recommended A, B, and C. And sometimes those recommendations don't seem to tally with each other, or it doesn't seem to make too much sense. And so one of the things that's really important, and I will try and just summarize this here, is the notion of what's called evidence-based medicine. That is, looking for the information, looking for the good published studies, making sure we can trust the information, and then trying to make a recommendation or a suggestion based on that. And what we talk about is recommendations which are based on a balance between beneficial effects and adverse effects, on the quality of the evidence, on patients' preferences, and on costs and utilization of resources. And we have strong recommendations where the notion is that most informed patients would choose that management or that treatment or that investigation because the evidence is good. But we also make suggestions where we don't have such good evidence, and that is where the discussion comes in. These are where patients' choices will vary according to their values and preferences. And unfortunately, when we read about this in the press, the strong and the weak recommendations, or the suggestions and the consensus recommendations, tend to get mixed up, which makes life really confusing. And so that's what I want to do in the next few slides, is to look at some of the recommendations that came out from the recent the Canadian Association of Gastroenterology's guidelines, which were published a couple of years ago, led by my colleague, Dr. Paul Moeidi. Now, one of the things that's important is to make sure before making a diagnosis of the irritable bowel syndrome that there is no indication of anything serious or worrying underneath that. And that's where we have this notion of alarm features or red flags. And so if somebody has symptoms of IBS, but they have vomiting, or they have an abdominal mass or lump when they have, they're being examined, if they have unexplained weight loss, evidence of bleeding, difficulty swallowing, or anemia, all of these are what are called alarm features. And these should generally be investigated before going on to treat as IBS. Now, that doesn't mean that the presence of these alarm features necessarily means that there's anything nasty or that there's cancer, but it's important to take them seriously. It is also important to recognize, however, that cancers are really uncommon, particularly in Canada under the age of 50. That doesn't mean never, but it means it's really uncommon. So in general, it's safe to treat and treat irritable bowel syndrome without doing lots of investigations. And that's here, this summary of 9 different suggestions is a summary of the Canadian guidelines on the need for testing. And what I want to highlight here is that there are only 2 areas where they suggest testing before going on to treat irritable bowel syndrome. And that is firstly looking for celiac disease with a blood test, what's called celiac serology. And then the other one is colonoscopy, but only for those who are over the age of 50 with new onset or recent onset irritable bowel syndrome symptoms. For all of the others, these investigations are not necessary to make a diagnosis of irritable bowel syndrome, and there's actually good evidence that they do not improve the outcomes. So diagnosing irritable bowel syndrome doesn't require a lot of tests. What it requires is a careful discussion and history to work out what the symptoms are and to make sure that we know what we're dealing with. Having made a diagnosis, then what do we do about treatments? Well, there are a number of treatments that we can look at, and I've summarized some of them here. I've started off initially with what are called dietary and alternative therapies, and we're looking at diets, we're looking at bran supplementation or fiber, herbal remedies, peppermint oil, and probiotics. And to summarize this, there is good evidence that a low FODMAP diet, that is reducing fermentable carbohydrates that make us feel gassy, that reducing those in the diet will improve symptoms for patients with IBS. There's low quality evidence and it's a suggestion, but at least there's a recommendation for that. There's a recommendation for fiber supplementation, but really only for soluble fiber, not for coarse wheat bran supplementation. And then there are data showing that peppermint oil is beneficial and is recommended, and also probiotics. Now, I'm going to show you some data for peppermint oil. I'll come back to probiotics later. But for peppermint oil, what we have here, and you can see this little black diamond down here, which shows that because it's to the left of this line, it shows that there is benefit from using peppermint oil as a treatment for IBS symptoms. And over on here, and you'll see this from a number of the other slides, we have this thing called NNT, or number needed to treat. And that means that if we treated 4 people with peppermint oil for IBS, one of those would feel better. So although there's evidence that it works, it certainly doesn't work for everybody. And that's one of the really important things about IBS, is that because it's complex and because there are a lot of different things that can lead to the symptoms, we may have to try a lot of different therapies before we find one that works. And so even if it's effective, this one, for example, only works for about 1/4 of the patients in whom it's tried. Having said that, it is still beneficial for some. The next area that I want to touch on before I come back to probiotics is psychological therapies. And again, to emphasize, this is not to say that IBS is a psychological or psychosomatic disease, but there's now good evidence that teaching people behavioral strategies will help them deal with the symptoms of IBS. And this is not ignoring a dangerous situation. What it's doing is helping people to work out how best to manage their symptoms so that they can enjoy the rest of their life. And there are good data for a number of different therapies: cognitive behavioral therapy, multi-component psychological therapy, and hypnotherapy. And for all of these, there is evidence of significant benefit, again, with numbers needed to treat overall of about 4 people, which means that psychological therapy is beneficial for about 1 in 4 people. There are other treatments, rather like peppermint oil, which try to deal with the symptoms, and we're looking at a couple here. Antispasmodics are things like Buscopan or Dicertel, which help to reduce the contractions of the bowel, and they are also effective in a proportion of people. The NNT, or number needed to treat, here is 5, which means that it's probably less effective than probiotics overall or than peppermint oil. And then we look at the antidepressants. Now, these are low-dose antidepressants. They're not being used because people are depressed, but what they're doing is altering the way that our brain perceives the symptoms and helping us deal with the symptoms of IBS. And here we're looking again at numbers needed to treat of about 4, which again means that there's a different type of treatment. Things like amitriptyline or citalopram are effective in about 1 in 4 people. Other treatments are now more directed at the different types of irritable bowel syndrome. So if we look at diarrhea-predominant IBS, IBS-D, the consensus group, the Canadian Association of Gastroenterology Consensus Group, recommended against regular trials of Imodium as an antidiarrheal or cholesterol to bind bile acids for the treatment of IBS-D. Now, that doesn't mean it doesn't work in some people, but as a first line, this was not recommended. And what they did recommend, however, was a medication called aloxadaline that blocks some of the receptors that cause symptoms and cause pain. And again, this was shown to be effective, but you can see here that the number needed to treat for a medication that has recently come on the market is about 12, which means you need to treat about 12 people to get 1 person better. So it works, but not as well as some of the other therapies. And now moving on to IBS-C, or constipation-dominant irritable bowel syndrome. The recommendation, the guideline group recommended against using laxatives or procalcipine for the symptoms of IBS. That doesn't mean it doesn't work for constipation. These are effective for constipation, but if we look for IBS, osmotic laxatives like PEG or lactulose are not effective, and nor is procalcipine. The treatments they recommended were lubiprostone and linaclotide. Linaclotide has a number needed to treat for about 6 for the IBS part of chronic constipation-predominant irritable bowel syndrome. So again, effective, but possibly less so than some of the other things that we're looking at. So I've taken you through a number of the different treatments that are available for the irritable bowel syndrome. And what I wanted to do now for today was to come back to probiotics with the question really coming on from the analysis from the Canadian guidelines showing that probiotics were recommended, to say, are probiotics effective for managing IBS? And when the Canadian guideline group summarized the data, what they showed was that overall probiotics, and particularly combination probiotics, were effective for the treatment of irritable bowel syndrome. These ones grayed out do show similar effects, but they're not significant because of the number of patients in the studies were not big enough to be able to confirm that this was a true evidence-based benefit. But overall, probiotics are statistically significantly superior to placebo for the relief of IBS symptoms. If you look at the overall symptoms, then the number needed to treat is about 7. Having said that, there is what was called significant heterogeneity between the studies. That is, the studies were all somewhat different from each other, and there's quite a lot of variability. So this is not that all probiotics are the same and they all have the same effect. One needs to be able to look at the different combinations and different probiotics to be able to try and pick out which one may be helpful. And when they looked at the studies, they found no significant benefit, as I showed you in the previous slide, from those studies which looked at a single probiotic on its own. What they did see was that the benefits seemed to be related to the combinations, The good news was that there was no difference between probiotics and placebo with respect to adverse events or side effects. So at least from the studies that they reviewed, probiotics were a safe way of treating IBS symptoms, even if they were not sort of fully predictable in treating symptoms in all people. So from that selection of probiotics, which are the ones that are effective? Well, I'm going to take you back to the clinical guide to probiotic products that published by AE ProBio and led and authored by Dragana Skokovic-Sunjic. And she has, in that guide, has summarized the probiotics that are available for the different indications in for probiotics for different conditions. And this is an annual publication, the reason being that this is a rapidly changing field, and it's really important to know which probiotics are available, which ones are effective with good evidence, and which ones have been approved by Health Canada. So if we look at the probiotics that are available for adult IBS therapy in Canada, you can see there's a list of 8 different probiotic formulations here. I'll summarize this a little bit later, but you can see, for example, here at the bottom, that there is a group of probiotics that is a mixture of different probiotics, that they're available as capsules or tablets in this case, that there are varying doses and varying strengths of these formulations, that some of them have level 1, that is good quality evidence supporting them, some have less strong evidence, but at least on this page, all of these probiotics have been approved by Health Canada. On the next page, the top 2 here as powders are basically the same formulation as the capsules that we saw at the bottom of the previous page, except they're now available as a powder. And then there's a number of others, again, some of which are single probiotics, some of which are mixtures. And again, some of these are approved by Health Canada, some are not. And again, there's varying degrees of levels of evidence to support their use. So, and then in addition to those as probiotic preparations, we also have some functional foods where probiotics have been added to the either the drink or the yogurt, and these too are approved for treatment of or for taking for adult irritable bowel syndrome. At least there's good evidence, even if they do not need Health Canada approval for marketing. So what I've shown you is that there are now 17 different preparations, 15 probiotic preparations at the moment in Canada, although I think one of them may be coming off the market. There are 2 functional foods that have probiotics, and there's quite a variation in the probiotics that are present, including the type and the amount. Having said that, over nearly half of them are basically the same formulation with a mixture of lactobacillus and bifidobacterium. All of the probiotics are based on lactobacillus or bifidobacterium species. There are a couple of other combinations, and then there are 7 which are single species probiotics. And that's important to remember when we look back at where the evidence was, which suggested that the combinations there was better evidence for the combinations than there was for the single preparations. And that doesn't mean that the single preparations don't work, but if we're looking for evidence-based recommendations or suggestions, then it's important to start with those for which there is good, high-quality evidence. So the commentary on this that I'd make is that we're really dealing with an exciting and important area, but the trials that we have assessed a variety of different combinations and specific species products, and there's a lot of variability, which makes it difficult to make specific recommendations. And to some extent, this is going to be always, there's going to be a degree of trial and error, arguably, however, with a safe preparation. Many probiotics are not regulated, so there are many other probiotics that are available that are not listed in this guide, and it's really difficult to know how many have live bacteria, how well they've been stored, how well they've been transported, and how effective they are. Probiotics do not come free, and therefore it's important when balancing out treatment to balance out the benefits against the cost, and to select products that have been licensed by Health Canada. So this again was one of the recommendations from the Canadian Consensus Guidelines. They also suggested that if one's going to try probiotics, one should consider a limited therapeutic trial. So basically what they mean is, don't try this forever. Take it for a month, take the probiotic for a month with a clear identification of the symptoms that one hopes are going to improve, and then assess that objectively at the end of the month to make sure that it's actually produced the benefit that's required. Because if there's no improvement in symptoms and one doesn't feel better, then there's no point in continuing to pay for a treatment that's not producing any benefit. So with all of that, what I want to do now is to show you a couple of slides, which are what's called a flow diagram or an algorithm from the Canadian guidelines, which shows how one follows through somebody who has IBS-like symptoms to do the appropriate investigations and offer the appropriate treatment. So what you can see over on the right-hand side in this red box is that the gray areas are recommended for most patients most of the time. Those that are hatched can be suggested after careful discussion with the patients about the options. So if somebody has symptoms of IBS, the first thing is to make sure that there are no alarm features and to then consider celiac serology testing for celiac disease, that is a blood test for celiac disease, and then colonoscopy if these are new onset symptoms and if the patient is over 50. If those conditions are not met, then the first recommendation is a consideration of soluble fiber supplements for those that are fiber deficient, moving on after discussion with suggestions to peppermint oil and antispasmodics. So that's the first kick at the can, if you like, for irritable bowel syndrome symptoms. If those work, then that's great. One doesn't need to do anything else. If, however, the symptoms are not settling down, or if there are clear indications that this is diarrhea predominant, mixed or unclassified IBS, or constipation predominant IBS, then one needs to consider other treatment options. And the treatment options here are for those who have diarrhea predominant IBS to consider a low FODMAPs diet, probiotics if that's unsuccessful, tricyclic antidepressants, eloxadoline, which is this pain management medication, and then the consideration for cognitive behavioral therapy or hypnotherapy. Very similar treatment strategy for those with mixed or unclassified IBS, again with a low FODMAP diet, probiotics, tricyclic antidepressants, and psychological therapy. And then for the IBS-C, a rather different approach, including the fiber that we talked about at the start, followed if needed by linaclotide, the selective serotonin reuptake inhibitors, low doses of this type of antidepressant, lubiprostone, and then moving on to psychological therapy. The treatments that were not recommended, as we saw at the start, included gluten-free diet at the start, wheat bran supplementation, herbal remedies, and a variety of other treatments here, which are available in the publication that you can see at the bottom. So I'm just going to finish with some practical pearls or comments around the management of irritable bowel syndrome. The first is that IBS is a common condition that has significant individual and socioeconomic impact. A positive diagnosis of IBS is recommended based on the history, the absence of alarm features, and the absence of risk factors for treatable or remediable organic diagnoses, with the goal of minimizing investigations, partly so that patients do not go through unnecessary investigations, and partly to make sure that the resources are best used in the healthcare system. The investigations that are considered are those to make a blood test diagnosis of celiac disease and colonoscopy for those who have alarm features or new onset symptoms if the patient is over 50. That the treatment is based for all patients with IBS on consideration of soluble fiber supplements, antispasmodics, through to psychological therapy. And then after that, those with diarrhea predominant or mixed or unclassified IBS should have a discussion about a low fermentable carbohydrate diet, probiotic supplements, and possibly tricyclic antidepressants. And for the constipation predominant, looking at linaclotide and the SSRI antidepressants. Probiotic therapy is an effective therapy option, but the risks and benefits should be based on a detailed discussion between the healthcare provider and the patient. And currently, the evidence for available probiotic therapies in Canada is most supportive of treatment with a probiotic combination based on a short-term treatment trial. That doesn't mean that the others won't work, but they're perhaps less likely to. And as with all of this, for complex treatment strategies, it's best to start with those where there is reasonable or good evidence and to make sure that they're tried appropriately. So with that, again, my thanks to AE ProBio, to Dragana, to Catherine for the opportunity to speak to you. and I shall do my best to try and answer some questions.
Dr. Armstrong, thank you so much. It's always great to listen to you, and we always learn something new. One of the things I just wanted to add, you mentioned, thank you for mentioning the probiotic guide and the resources we have. Reminder, there is also equivalent publication for the US market, where there is a different list of products names, but the same evidence is listed. And also you talked about probiotics in IBS in adult population. There is a list for the pediatric population with only few probiotics listed. Some of them are single strains like Lactobacillus reuteri, which is available as BioGaia or Gerber products in the US, BioGaia in Canada, Culturelle or LGG, Lactobacillus rhamnosus GG in both countries, and good evidence for Visbiome, which is combination products available both in Canada and US. We have lots of questions and lots of comments. Some of them you have already answered. One of the questions was about the length of time, how long the patient needs to try probiotic before determining that if it works or not.
So I think, Gerald, the recommendations were that a month is a reasonable treatment trial. And basically, that's not to say that one would necessarily expect a full benefit by that time. But if there has been no discernible benefit after 4 weeks, it's, I think, unrealistic to expect that a treatment will then become effective after that time. Now, one of the caveats with all of these is that it's important, as with many complex conditions, to try and test or evaluate one thing at a time. So if you're going to try some probiotics, that's probably not a good idea to do it while you're going on holiday, traveling, eating a different diet in a stressful period of your life, and hoping that the probiotics are going to neutralize all of the other things as well. So if you want to know whether something's going to work, it's best to have everything else stable, and stable in the background as a base for then being able to determine whether or not any of these treatments has a benefit.
There are a few questions about soluble fiber. First one is it a first line of therapy to be soluble fiber, peppermint oil, and etc. for all cases? And on top of that, there was a question about the recommending the psyllium fiber, and does it dose different according to the type of IBS?
So there is. I mean, the guidelines are necessarily a simplification of the overall management strategy. If one tried to do all of the possibilities, then you finish up with what's called spaghetti, which because all of the lines join up to everything else. So I think one of the important things is, and I try to emphasize this, is actually a discussion with between the patient and the healthcare provider about what people's baseline diet is. So if somebody already has a good fiber intake, then adding more fiber on top of that is probably not going to be helpful. If somebody's got a good fiber intake and they have diarrhea, then adding more probably isn't going to do very much. If somebody has relatively little fiber intake and they're constipated, then there's likely to be much more benefit. One of the interesting things is that most of us have no idea how much fiber we take. We know that we should be having somewhere about 25 to 35 grams. We tend to think that certain foods look healthy and therefore should contain fiber. I would argue you can probably eat half a ton of lettuce and you won't necessarily get a lot of fiber out of it. So you need to work out what you're actually eating. And I find when talking to my patients, the recommended 25 to 35 grams, most people fall far short of that. So depending on people's diet, depending on what symptoms they have, depending on whether it's a mixed picture where I find that some people get constipated and then they treat the constipation, then they get diarrhea and they go back to being constipated, having a stable baseline diet may be helpful. But it's not a one size fits all. It's based on a discussion. And that's where consultation with a dietitian is really important, because although I do try and get a history out of it, I am the world's worst dietitian. And what you need is to talk to somebody who actually knows with some degree of confidence what the different constituents of different foods are.
Absolutely. And this is, again, underlying the team approach. Absolutely. Dietitians and everybody else, the team approach to that. Next questions, a few of them are about the peppermint oil. Does it have to be enteric coated? And what dose and frequency of use for peppermint oil?
So again, there's a lot of variability around this. It's interesting. I trained, as you will have heard from Dragana's very nice introduction. I mean, I did some of my training in the UK, and I can remember soon after qualification prescribing Colpamine, which was a peppermint oil preparation that was available in the UK and Europe, and then being somewhat upset when I came to Canada and it wasn't available. So that was a non-enteric coated version. Now, the challenge with a non-enteric coated version for some people, particularly if they have reflux, the peppermint oil can relax the lower esophageal sphincter and may make people more likely to get reflux. So the enteric, it's not that it has to be enteric coated, and many of the studies were done with the non-enteric coated versions. But again, one needs to be aware of the fact that the non-enteric coated versions may be more likely to cause some side effects or other symptoms. The enteric coated versions are probably a little better tolerated. It really comes down to availability. And as far as I know, I haven't seen any preparations of the non-enteric coated version in Canada, although they may be available. The dosage really is based on the recommendations that come from the manufacturers. So I take it because it depends how much peppermint oil is actually in each of the sort of tablets or capsules.
Okay, next question is, if probiotics work, any danger to take it forever?
I don't think so. I mean, again, part of this comes down to evidence base, and so we don't really have any studies where people are taking probiotics for years on end. We have no documentation of that. I mean, having said that, in day-to-day life, we take bacteria in and all sorts of other things as part of our day-to-day food. So my view is that if you're taking any medication, or if you're taking a probiotic and it's beneficial and you have not noticed any side effects from it, it's highly unlikely that you're going to have major long-term problems with taking it. Now, one of my recommendations for many treatments, and that includes treating reflux or anything else, is have a discussion with your healthcare provider, because it may well be that after a period of treatment, your inside or your gut may well have stabilized, and you may well be able to reduce your medication, whatever it is, in consultation with your physician or your healthcare provider, and may find that if things have stabilized, you don't actually need to take it forever and a day. I mean, the other thing is, if you felt better taking a yogurt every morning, then nobody would say, well, you can't take the yogurt forever. If that's your eating habit and you like a Greek yogurt or something else every morning, then that's part of your life. And so that it's not that different in concept for probiotics, providing you get benefit and don't get side effects.
There's a question specifically about Visbiome, which was previously known as VSL number 3. Can it be helpful for IBS constipation predominant?
So I'm actually not sure. I think the answer to that, which goes back to the way that I try to present the data, is that guidelines try to work with the evidence that's available. And I'm not aware that there are good studies with VSL3 or Visbiome that it has been shown to treat constipation. That doesn't mean it may not work for some people, but in terms of recommendations and the discussion with your healthcare provider, there's very little evidence, I think, to support it.
Yeah, so in a guide, we have it as listed as level 2 evidence, which is not level 1 for constipation. And we also have it listed for the IBS in pediatric population. So it's something that, it'd be good to discuss with your healthcare provider about it.
I think all of these are up for discussion. And I think the other thing, if you go back to that diagram that I showed you, the interaction between different parts of the gut, the microbiome, the enteric nervous system, and everything else, we actually have insides that are not just general sensing machines. They actually learn what works for us. They learn what foods we do and don't like. And so trying to predict what's going to happen with a probiotic in somebody who's got a history that includes a particular diet in a particular place is very difficult if you then try and apply it for somebody who's born on the other side of the world and eats a completely different diet. So I think there are a number of things that we need to think about within this.
Also, interesting question is, why are the rates of IBS so high in Canada?
That's a very good question. In all honesty, I don't know. I mean, I can speculate. One can speculate that Canada is actually a huge country with tremendous diversity in diet and socioeconomic and ethnic backgrounds, which means that there may well be significant variations in our diets and our sort of microbiome, which then lead us to run into trouble. It may also be, however, that this is one of the countries in the world that has a national healthcare system, or a sort of free at the point of care healthcare system, which will tend to raise the profile of functional disorders like the irritable bowel syndrome. So I think there are a number of things that will play into this. And it's always very difficult to compare the data across different countries.
Okay, next question is about going back to the probiotic. Would the analysis of the microbiota help in managing the best probiotic?
That's a fascinating question. Will knowing the microbiome basis help pick the probiotic? And I think it's a thought that makes a lot of sense. The difficulty is the relative numbers of bacteria in the microbiome and our ignorance, if you like, as to whereabouts in the bowel the symptoms come from. So the small bowel is about 30 feet long, the colon is about 5 feet long, and somebody with irritable bowel syndrome doesn't necessarily have symptoms arising from the entirety of the bowel. So then we've got to work out which bit of bowel is causing the problems. And we've then got to say, if we put probiotics into that mixture, will they get to the right place and will they have the right effect? And do we know what the microbiome mixed sort of makeup is in that area? Because the microbiome, actually what we sample, varies as we go down the bowel. So if you take something that has 50 billion live organisms in it, or colony forming units, that sounds like a huge number. But our microbiome in the colon has something like 10 to the 14, which means there's about another 100,000 times more bacteria in the colon than you have in that capsule. So it's really difficult to predict which bit of the microbiome is going to be hit by the probiotic. So at some point down the road, we may well do, and we may be able to work out the people who have a particular makeup that are going to respond better. But I think that's a long way in the future.
Absolutely.
Is my speculation.
I believe most of the experts agree on that. I know that it sounds very fascinating and very, the people do pay lots of money to have analysis, and we don't really know what to do with the results. Also, I spoke with Dr. Martha Carlin, which is one of the leading researchers that does analysis of microbiota. And, she said, we analyze, but we don't know, because from the same sample of the stool, depends how deep we go to the core to pick up the sample to analyze, we have different composition. So even if the same sample, the different parts of it will get different composition of bacteria. So I would say at this point, it's still too early to do it as a mainstream.
I think it's a really interesting comparison if you think about it. So when we do microbiome analyses, we don't do deep analysis. We go down to the level, in some cases, of particular species, but not down to strains. And the importance of that actually is illustrated by all of the publicity and the news at the moment about COVID strains. So we're talking about minor changes in a virus that lead to huge changes in behavior. And there is no way that we type our microbiome, or we can type it down to the level at which we're having to type the coronavirus to deal with that. So if you think about that in comparison, we have an awful lot of information that we need to understand way better about the microbiome before we can target particular makeups of the microbiome.
Absolutely. Also a question about probiotics. How would you recommend integrating probiotics with antibiotic therapy?
Certainly probiotics are used and they will protect against some of the side effects of antibiotics. So the notion and against Clostridioides difficile. So it's not that you shouldn't mix them. It's sort of, there's a school of thought that if you take a probiotic, then taking an antibiotic will negate its effect. And that's probably very simplistic because antibiotics are quite targeted, and unless the probiotic is specifically sensitive to the antibiotic, there probably will be little in the way of direct interaction. So that there's no, for most things, there's no direct reason why one shouldn't mix the two. Having said that, what I said before was that mixing treatments and then trying to work out which treatment has led to the improvement makes life very complicated. So looking at one thing at a time is probably the best basis anyway for moving forward.
Absolutely. There was also a comment in the chat box asking about why our studies do not line up with the probiotic company through Australia by Dr. Jason Havrelak. He has a company called Probiotic Advisor. This just illustrates there are different resources for information on probiotics, and sometimes they are tied with a specific market. There are international resources such as International Society of Scientific Group for Probiotics and Prebiotics, or ISAP, that will provide the science globally for all probiotics, which is a great resource. Also, we have the guides, which is an AProBio, which looks at the products in Canada and US, because again, the names will be different. What format they are available will be different. So this is what we are trying to make it as clinically relevant and practical for the particular region. Australia is a huge country and again, continent, and has their own availability of strains and products. So yes, there are resources in different countries. There are a few more questions. One of them is very particular, and it's from breast cancer survivor, currently on anastrozole, and she's asking about what tricyclic antidepressant she should use. I believe that's a question for your individual healthcare provider. And then there's also a question about any evidence about the strains in Visbiome and lowering oxalates. Which,
in all honesty, I don't know. I'm sorry.
Yeah.
I mean, it may alter it, but I'm not sure.
Yeah, I would say if you would like to send us a question to AProBio, we'll ask our resource and experts to see if they can answer. Also, that there's a comment about colony forming units. If you take 50 billion versus 20 billion, etc., do you have any comments on amount of colony forming units or CFU in probiotic products?
That's a very difficult one because colony forming units are not necessarily comparable across all different bacteria or different probiotics. To some extent, the number of CFUs that goes in each preparation is based on an evaluation of the extent to which those bacteria will survive as they go through and how many of them are needed to achieve an effect. And because they're different bacteria, they may well be achieving different effects. They're not all doing the same thing when they go through. And the other thing is that they probably have differing sensitivities to gastric acid, to digestive enzymes, and to the bowel as well. So this is not a way of comparing different things, different probiotics in terms of a 50 billion unit preparation is necessarily better than a 2 billion unit. It may be that the 2 billion unit actually survives better in the gastrointestinal tract and therefore will be more effective. It's just whatever's needed. It's like other medications. There are some medications where you only need 0.1 of a milligram to be effective. There are other medications that need 1,000 milligrams to be effective. And it's not a commentary on their sort of relative efficacy. It's really how much of it is needed for that particular preparation to produce the benefit that's required in that individual.
Exactly. It kind of comes back to the strain specificity. And I'm going to conclude with a comment we got, about the IBS prevalence, asking if that could be maybe something to do with the vitamin D levels, exposure to sun, I guess, as well, which I thought it has maybe some correlation, but on your slide, on your map, I saw one of the countries that is much closer to the equator than Canada with much higher prevalence of IBS. So that theory, I'm not sure how relevant that is.
So it's a very difficult one. I mean, there is also the fact that I've got colleagues in gastroenterology from the Caribbean, and things like vitamin D deficiency are not uncommon there either, because although there's a lot of sun, they will often keep out of the sun. And so it comes down partly to diet and partly to sun exposure. And, Canada covers everything from the Great White North down to where we are, which is, almost Mediterranean in its lines of latitude.
Okay, I'll take that word from you with some layer of snow we have right now. So with this, we are approaching 1 o'clock. So on behalf of the Alliance for Education on Probiotics, I would like to thank Dr. Armstrong for sharing these insights and expertise with us. Executive Pharma as well for funding this event, and for you, all of you, for joining us. We hope that this presentation on enlisting probiotics in the management of IBS has provided you with valuable information that you can incorporate in your clinic. And please plan to review this session and 3 others in this series, when we have questions about probiotics in liver disease or IBD and IBS, when these questions arise in your future. All of these sessions are available on our website or APROBIO website. And again, we will be receiving the links to recorded sessions in a follow-up email. And again, remember that the clinical guide to probiotic products, both US and Canada, is available in print, online as an interactive website, or as a mobile app for your smartphone. And again, do visit the APROBIO website very often, as the content is constantly being added and changed, and this session will be added to previously recorded sessions for your own viewing at your own leisure when it's convenient. And it will remind you that we are here to support you. We strongly encourage you to complete the post-event survey that will pop up after you log out to provide your feedback on this session and let us know what topics you would like to see us explore in the future. Again, thank you again for joining us, and this concludes our session. Thank you, Dr. David Armstrong.
Thank you very much for inviting me, and I hope everybody has a good day and ultimately a Merry Christmas.
Stay safe.